1, 2,
And review 70-year-old female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah.
Here, what do the ECMO people say?
And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh.
Okay.
Oh.
You know, usually when we talk about a medical diagnosis, there's this expectation of, well, precision.
Right. It's binary, you know, it's objective.
Yeah, exactly. It's almost like engineering. I mean, you break your arm, you go into the clinic, the x-ray shows that jagged white line on the screen, and the doctor just points at it and says, there it is.
And it's comforting. As humans, and especially as clinicians, we like things to be visible. We like to be able to categorize a problem instantly.
Totally. Broken or not broken, it's a clean line. You cast it, you wait, you're done. But then you step into the world of obstetrics, right? Or neurodevelopment and newborn transitions, and suddenly it feels like that x-ray machine is just broken.
Oh, absolutely broken. It is the absolute definition of diagnostic muddy waters.
Right. We're looking at a landscape that is honestly just murky, especially when you're dealing with a neonate. I mean, they can't just point to their chest and tell you what hurts.
No, they really can't. A neonate has this incredibly limited repertoire of behaviors to tell you that something is going catastrophically wrong. And that is exactly why we are here today.
Exactly. So welcome to this special deep dive. If you're listening to this, you are likely preparing to step onto the floor as a nurse. Or, you know, maybe you're gearing up for a massive exam like the NCLEX.
And today, we are essentially stepping into the roles of your clinical preceptors.
Right. Imagine we're just pulling you aside before the shift starts, getting coffee, and saying, look, here is exactly what you need to look out for to keep these babies safe today and, well, to crush your exam.
Because your time's incredibly valuable.
Yeah.
You know, you do not need us to sit here and read a textbook to you chapter by chapter. What you need is to know how to think clinically.
Yeah, we are aggressively applying the Pareto principle today.
Exactly. We are going to sift through all the noise and deliver the 20% of high-yield OB and newborn nursing concepts that will give you 80% of the value.
Right. The value for when you're taking those exams or, honestly, when you're just standing in front of a warmer. We want you to be the safe nurse, the one who catches the subtle drop in temperature before the baby crashes.
So our roadmap today is going to cover the absolute most highly tested, high-stakes areas of newborn complications.
We'll talk about respiratory battles, which, you know, is always priority number one. Then we'll move into the metabolic traps of maternal diabetes and hypertension.
And then we'll decode the yellow flags of jaundice, visualize some major structural anomalies, and finally tackle high-risk exposures and infections.
It's a lot of ground to cover, but we're going to break it down not just by what you see, but, well, why it's happening.
Because if you understand the why, you don't have to memorize a list of symptoms. You can just deduce what the baby's going to do.
Okay, so let's unpack this. Let's scrub in and start with the most fundamental priority of any nursing exam, and really of life itself, the airway and breathing.
Yes, the breathing battles. So we're going to format this by giving you the high-yield core first.
Okay, so imagine we're looking at a few different babies in the nursery. My understanding is that the specific respiratory issue in newborn faces is almost entirely dictated by their gestational age and, well, how they were delivered.
That is exactly the framework you should use. The exam and real life will almost always give you the gestational age and the birth history as your primary diagnostic anchors.
So what are we looking at, like, profile-wise?
Let's look at three classic profiles. First, you have the premature newborn. When you see premature, your brain should immediately think Respiratory Distress Syndrome, or RDS.
Yet RDS is fundamentally a problem of missing hardware, right? Or wait, rather, missing chemicals? The lack of surfactant?
Precisely. Surfactant is this phospholipid mixture produced by type 2 pneumocytes in the lungs.
Right.
Its entire job is to reduce surface tension inside the alveoli, those tiny air sacs in the lungs.
I always think of the wet balloon analogy for this. Like, have you ever tried to blow up a balloon that's totally wet and stuck together on the inside?
Oh, yeah. It's nearly impossible.
Yeah, right. It takes immense painful force to get that first breath of air in to pop it open. But if the inside is coated in powder, it inflates easily. So surfactant is basically that powder.
That's a brilliant way to look at it. Without surfactant, every single time the premature baby exhales, those tiny alveoli completely collapse and stick shut.
Wow, so they have to start from scratch every breath.
Exactly. The baby has to use massive amounts of energy to pry them open again with the next breath. Eventually, they just tire out.
Okay, so that's the preemie. What about a term baby?
Right. Contrast that with our second profile, a term or late preterm baby born via C-section. They have plenty of surfactant.
But they still have breathing issues.
Yes, their issue is transient tachypnea of the newborn, or TTN.
Transient meaning temporary, and tachypnea meaning fast breathing. So why does a C-section cause fast breathing? I mean, they're term, right?
It comes down to the mechanics of birth. In utero, a baby's lungs are filled with amniotic fluid. When a baby is delivered vaginally, the physical compression of the chest, as they are squeezed through the birth canal, literally wrings their lungs out like a sponge.
Oh, the famous vaginal squeeze.
Exactly. It forces a huge amount of that fluid out of the mouth and nose. But if a baby is born via planned C-section, they completely bypass that squeeze.
Right, they're just lifted out.
They're lifted out with their lungs still full of fluid. The lymphatic system has to work overtime to absorb it, and in the meantime, the baby has to breathe incredibly fast, tachypnea, just to get enough oxygen around that leftover fluid.
Okay, so preemie equals RDS. C-section equals TTN. What about our third profile, the post-term baby? You know, the one who stayed in the oven a little too long.
That is your classic setup for Meconium Aspiration Syndrome, or MAS.
Okay, why?
A post-term baby has a more mature digestive tract. If they experience any kind of stress or hypoxia in utero, maybe the placenta is starting to degrade because it's past its expiration date.
Right, their physiological response to that stress is that the anal sphincter relaxes.
Yes, and they pass their first stool, the meconium, directly into the amniotic fluid. And meconium isn't just normal poop, it is thick, sticky, and tar-like.
Ooh.
And dangerous, highly dangerous. If the baby takes a gasp while still in the womb, or takes their first breath before the airway is cleared, they inhale that tar right into their lungs.
Which creates like a ball valve effect, right?
Exactly. Air can get in, but the sticky meconium blocks it from getting out. It traps the air, causing hyperinflation and severe respiratory distress.
And just to round out the breathing battles, we also see apnea of prematurity, or AOP. This is just the premature brain literally forgetting to breathe, right?
Essentially, yes. The medullary respiratory center in the brain is immature. It doesn't respond to rising carbon dioxide levels the way a mature brain does.
So how do we define that clinically for the exams?
We define AOP very specifically. It is a pausing of breath for greater than 20 seconds, or a pause of less than 20 seconds, but it's accompanied by bradycardia, a heart rate drop, or an oxygen desaturation.
Okay, so why does all this matter? Why are we hammering these ABCs, airway, breathing, circulation, so hard? I know it's the holy grail of NCLEX prioritization, but physiologically, why is a neonate's breathing so much more critical to monitor than an adult's?
It's about reserve capacity. An adult has a large functional residual capacity in their lungs. They hold extra oxygen. A newborn's reserve is incredibly small.
So they crash faster.
Much faster. Hypoxia in a neonate doesn't just mean they are short of breath. Because they can't get oxygen, their cells instantly switch to anaerobic metabolism, which produces lactic acid.
Which leads to acidosis.
Rapidly leads to metabolic acidosis, yes, which depresses the heart muscle, leading directly to cardiac arrest. When a neonate crashes, they don't give you a long warning. They crash fast.
Which means we need to know the difference between what's expected and what should make us sprint across the room.
Right. The expected versus concerning findings.
What is normal breathing for a newborn?
It is entirely normal for a newborn to have what we call periodic breathing. They might take a few rapid breaths, then pause for 10, maybe 15 seconds, and then start breathing normally again.
Just random pauses.
Yep. As long as that pause is under 20 seconds and there's no color change and the heart rate stays steady, you just document it. It's expected.
Okay, but what are the red flags, the signs that they are working too hard?
The big four are expiratory grunting, nasal flaring, subcostal or intercostal retractions, and central cyanosis.
Let's break those down because I don't want to just memorize them. Grunting, that's a very specific sound. Why do they grunt?
Grunting is a compensatory mechanism. When the baby exhales, they partially close their glottis, the opening between the vocal cords.
Right.
By exhaling against a closed door, so to speak, they increase the pressure inside their lungs. They're trying to create their own positive and expiratory pressure, or auto-PEEP, to keep those alveoli from collapsing.
Oh, wow.
Yeah, if you hear grunting, the baby is telling you, I am struggling to keep my lungs open.
And flaring.
Nasal flaring is an attempt to decrease airway resistance. By widening the nostrils, they are literally trying to make the pipe bigger to pull more air in.
And retractions. That's when you see the skin sucking in around the ribs and the collarbone, right?
Right. Normally, the diaphragm does the work of pulling air in, but if the lungs are stiff, like in RDS, the diaphragm isn't strong enough. So the baby recruits accessory muscles.
They use their chest wall muscles to yank the rib cage up and out.
Exactly. That massive negative pressure sucks the skin in between the ribs. It means they are burning a huge amount of calories just to breathe.
So when I see a baby grunting and retracting, what is my very first move? What's my priority nursing action?
Your first action is assessment, specifically getting a pulse oximeter on them, but not just anywhere. You place a productal pulse oximeter on the right hand or right wrist.
Okay, stop right there. I need to ask for clarification on this because it comes up all the time.
Sure.
Why the right hand specifically? Is it because the blood hasn't mixed with unoxygenated blood from the ductus arteriosus yet?
You hit the nail on the head, but let's visualize the anatomy for a second. The heart pumps oxygenated blood out of the left ventricle into the aorta.
Okay, following you.
The very first branch that comes off the aortic arch is the brachiocephalic artery, which feeds the right arm and the right side of the brain. After that branch, there is a fetal connection called the ductus arteriosus, which connects the pulmonary artery to the aorta.
And if that ductus is still open, unoxygenated blood from the lungs can shunt over and mix into the aorta.
Exactly. But because the right hand branches off before that mixing point, it gives you the productal reading. It is the purest, most accurate reflection of the oxygenated blood that is going directly to the brain.
Oh, that makes so much sense.
Right. If you put the sensor on the left hand or the feet, you get a postductal reading, which might be lower due to that mixing.
Here.
We want to know exactly what the brain is getting.
Okay, so we get the reading and the baby needs oxygen. If it's a preemie, I know we have to be incredibly careful. We titrate the oxygen to target a saturation of maybe 90 to 95%. We absolutely do not want 100% saturation on the monitor. Why?
Oxygen is a drug, and in premature infants, it can be a highly toxic one.
Really?
Yes. Their antioxidant defense systems are virtually non-existent. If you blast a preemie with 100% oxygen, it creates massive amounts of free radicals.
Which causes damage.
Severe oxidative damage to immature organs. Most notably, it causes the blood vessels in the eyes to grow abnormally, a condition called retinopathy of prematurity, which can lead to permanent blindness.
Wow. Too much of a good thing is literally blinding. What about interventions for the other conditions, like MAS, the meconium aspiration?
For MAS, because that meconium is irritating the lungs, it often causes the pulmonary blood vessels to clamp down, leading to pulmonary hypertension.
So blood can't get to the lungs to pick up oxygen.
Right. So you must anticipate the need for inhaled nitric oxide, or INO. Nitric oxide is a potent pulmonary vasodilator. It relaxes those vessels and lets the blood flow.
Let's pivot to the top exam traps here because the instructors love these traps. Here's a classic one. Confusing maternal versus fetal medications. A question we'll talk about lung immaturity and list betamethasone and surfactant as options.
Oh, they love that one.
Yeah.
And you have to know exactly who gets what. Betamethasone is a corticosteroid. It is given intramuscularly to the pregnant client, the mother, prior to delivery, ideally 48 hours before birth.
Okay, so it goes to the mom.
Yes.
Yep.
It crosses the placenta and signals the fetal lungs to speed up their development and make their own surfactant.
But once the baby is born, betamethasone is useless.
Correct. After birth, you give exogenous surfactant directly to the newborn. And you don't give it through an IV. You instill it directly down an endotracheal tube into the lungs so it can coat those alveoli. Don't mix up the patient and the route.
The second trap I see all the time involves feeding a tachypneic baby. You have a baby with TTN, they miss the vaginal squeeze, they are breathing at 85 breaths per minute. They start crying. The exam will offer feed the baby to soothe them as an intervention.
And if you choose that, you just compromised your patient. If a newborn's respiratory rate is above 80, you must keep that baby strictly NPO, nothing by mouth.
Why? Just because they were too tired?
No, it's a mechanical impossibility.
Right.
To feed, a newborn has to coordinate a very complex reflex.
Yeah.
Suck, swallow, breathe. Suck, swallow, breathe.
All right.
If they are panting at 85 breaths a minute, they cannot coordinate that sequence. If you put a bottle or a breast in their mouth, they will inhale the milk straight into their lungs. The aspiration risk is massive. You provide IV fluids or an NG tube until that respiratory rate drops.
Okay, so if I'm taking notes for my clinicals or my exam, my biggest memory anchors are TTN is transient fluid from no squeeze. MAS is mature babies under stress. And if you only remember 5 things from this section.
Number 1, RDS is a surfactant deficiency problem.
Yeah.
Number 2, TTN happens when fetal lung fluid isn't cleared.
Number 3, MAS requires immediate assessment for vigorous versus non-vigorous activity. Number 4, AOP is treated with caffeine citrate and tactile stimulation.
And number 5, never feed a baby orally if their respiratory rate is over 80.
That is the core of respiratory safety.
Exactly.
Which leads us perfectly into our next major topic. We've secured the airway. Now we have to look at what's pumping through the blood, specifically the fuel, sugar. Let's dive into the sugar and size traps, focusing on how maternal conditions directly alter newborn metabolism.
This is a fascinating area of physiology because it shows how intimately connected the maternal and fetal environments are. Let's look at the high-yield core for 2 maternal conditions that sit at opposite ends of the spectrum: maternal diabetes and maternal hypertension.
Okay, let's start with maternal diabetes. When a mom has poorly controlled diabetes, whether it's pre-existing or gestational, the baby comes out looking like a linebacker. Macrosomia, they are large for gestational age, or LGA. Why?
Because maternal blood glucose crosses the placenta via facilitated diffusion. It moves easily from the mom to the baby. But maternal insulin, the hormone that processes that sugar, is a huge molecule. It does not cross the placenta.
Oh, so the baby is getting flooded with mom's high sugar, but gets none of mom's insulin to handle it.
Exactly. So the fetal pancreas realizes it's drowning in sugar, and the beta cells in the pancreas undergo hyperplasia. They get bigger and multiply. The baby starts pumping out massive amounts of its own insulin to deal with the sugar load.
And here is where it connects to the size. Insulin isn't just a sugar regulator. In utero, it acts as a primary growth hormone.
Yes. All that extra insulin drives glucose into the fetal cells, converting it into fat and glycogen. The baby grows rapidly. They become macrosomic.
I always think of it like a car engine. In utero, the baby is getting this massive stream of high-octane fuel, the sugar. So the baby's pancreas stomps the accelerator down on insulin production to handle it. Then birth happens. The umbilical cord is cut. The fuel line is completely severed. But the baby's pancreas doesn't know that yet. The accelerator is still stomped down.
Yep, they are still pumping out massive amounts of insulin, but there is no more sugar coming from mom.
Of course, the engine stalls out.
Exactly. The excess insulin rapidly pulls whatever little glucose the baby has left out of their bloodstream and into the tissues. And suddenly you have a massive crash. Severe neonatal hypoglycemia.
That is such a vivid picture. Now, let's contrast that with maternal hypertension. The mom has high blood pressure, maybe preeclampsia. The baby comes out looking completely different. They are intrauterine growth restricted, or IUGR, or small for gestational age, SGA. Why?
Well, in hypertension, the maternal blood vessels are chronically clamped down and constricted. This includes the vessels feeding the placenta. Because blood flow is restricted, the placenta cannot deliver adequate oxygen or nutrients to the baby over a period of weeks or months.
So it's chronic hypoxia.
Yes. And the fetus is incredibly smart. When it senses it's not getting enough oxygen or fuel, it shunts the available blood to the vital organs, the brain and the heart, and shunts it away from the liver, muscles, and fat stores.
So the body basically just stops growing.
They are born small, with very little glycogen stored in their liver, and almost no brown fat.
Which means they are also at huge risk for hypoglycemia after birth, but for a totally different reason than the diabetic baby.
Exactly. The diabetic baby has too much insulin. The hypertensive baby just has zero fuel in the tank to begin with. 2 different roads leading to the same dangerous destination, hypoglycemia.
And why does this matter so much? Why are we terrified of a low blood sugar in a neonate?
Because the neonatal brain runs almost exclusively on glucose. It cannot use alternative fuels efficiently yet. If the brain doesn't have glucose, neurons start to die. Undetected hypoglycemia rapidly leads to brain injury, irreversible seizures, and permanent neurological deficits. You simply cannot ignore low blood sugar.
Okay, so expected versus concerning. What are we looking for? What is normal and what is a red flag?
We want to see a newborn maintain a blood glucose of 45 milligrams per deciliter or higher before feeds. Now, right after birth, during those first 4 hours of transition, they might dip a bit, and anything over 40 is generally considered acceptable as they regulate.
But what does the baby look like if they are crashing, like concerning signs?
The absolute hallmark sign is jitteriness. If you unwrap a baby and their arms and legs are shaking or exhibiting tremors, your brain should immediately flash a warning light.
It could be drug withdrawal, but mostly it's sugar.
9 times out of 10, it's sugar. You will also see lethargy, a poor suck reflex. They just won't latch hypotonia, meaning they feel floppy like a rag doll and a very weak or high-pitched cry.
If I see those jitters, what is my priority nursing action?
You perform an immediate heel stick point-of-care test. Do not wait for a phlebotomist. Do not send it to the lab and wait an hour. Get a reading instantly.
And if it's, say, 30?
You intervene immediately. If the baby is alert enough to swallow, you initiate an early feeding, breast milk, or formula. If they're too lethargic, or the protocol dictates, you administer a buccal glucose gel.
Oh, a gel.
Right. We typically use a 40% dextrose gel, dosed at 200 milligrams per kilogram, and you massage it directly into the buccal mucosa, the inside of the cheek. It absorbs right into the bloodstream.
And if that doesn't work?
If that doesn't work, you must be prepared to start an IV with dextrose 10% in water, D10W.
And there is another crucial nursing action here that ties into metabolism, keeping them warm, maintaining a neutral thermal environment.
Oh, this cannot be overstated. Cold stress is a massive enemy of the neonate. Newborns do not shiver to create heat.
Wait, really? They don't shiver?
No, they rely on non-shivering thermogenesis, which means they metabolize a special type of fat called brown fat.
But burning brown fat requires huge amounts of oxygen and glucose.
Exactly. If a baby gets cold, they will literally burn through all their blood sugar and their oxygen just trying to get warm. So, cold stress equals sugar stress, which leads to hypoxia. It is a vicious cycle. Keep the baby warm and you protect their sugar.
Let's talk about the top exam traps for size and sugar, because I see nursing students fall for this all the time. The scenario describes a 10-pound, 2-ounce baby, plump, ruddy skin. The student thinks, oh, what a robust, healthy baby.
And that is a deadly assumption. An LGA baby from a diabetic mother is highly fragile. They're essentially a giant preemie. First, they are at immense risk for the hypoglycemia we just discussed. Second, they are at risk for polycythemia.
Too many red blood cells.
Right, because they were constantly growing and using oxygen in utero, they produced extra red blood cells to carry more oxygen. At birth, all those extra cells make their blood thick and sluggish, which can lead to clots and hyperbilirubinemia when those cells break down.
And third, and this is a big one for exams, birth trauma. A 10-pound baby does not fit easily through the pelvis.
Precisely. You must aggressively assess LGA babies for shoulder dystocia injuries. When the head is delivered, but the shoulders get stuck behind the pubic bone, the provider has to use maneuvers that can fracture the baby's clavicle or stretch the brachial plexus nerve bundle.
How do I assess for a fractured clavicle? I mean, I can't ask the baby to move their arm.
You palpate the collarbone. You are feeling for crepitus, a popping, crackling feeling under the skin where the bone ends are grinding together.
Oh, wow.
And you check the Moro reflex, the startle reflex. If you startle the baby and they only throw one arm out and the other arm stays pinned to their side, that asymmetric Moro reflex tells you the arm that didn't move has a fractured clavicle or nerve damage.
Wow. Okay, memory anchors. Diabetic mom equals big baby, low sugar. Hypertensive mom equals small baby, high stress. If you only remember 5 things here. Number 1, insulin acts as a growth hormone in utero, causing macrosomia.
Number 2, assess LGA babies for birth trauma. Look for crepitus and asymmetric Moro.
Number 3, jitteriness in a newborn means check blood sugar immediately. Number 4, hypertensive moms have restricted placental blood flow, leading to SGAI-UGR.
And number 5, cold stress equals sugar stress. Keep these babies warm.
That is the perfect clinical summary. Now, we mentioned polycythemia and the breakdown of all those extra red blood cells. That is the perfect bridge to our next major focus. It's time to talk about the yellow flags of neonatology, hyperbilirubinemia and blood incompatibilities.
This is an incredibly common issue, but the exams test your ability to distinguish between what is a normal physiological process and what is a pathological emergency. That's the core here.
Let's start with the basics. Why do babies turn yellow?
When red blood cells reach the end of their lifespan, they break down. One of the byproducts of that breakdown is unconjugated bilirubin. It is a fat-soluble yellow pigment.
Okay.
In an adult, the liver takes that fat-soluble bilirubin, conjugates it, meaning it makes it water-soluble, and then it's excreted into the intestines and leaves the body in our stool.
But a newborn liver is like a new employee on their first day. It's immature, it doesn't process things very fast. And to make matters worse, fetal red blood cells have a shorter lifespan than adult cells.
Right, so there's a massive demolition derby of red blood cells happening right after birth.
So high volume of breakdown, slow processing by the liver.
Exactly. The unconjugated bilirubin builds up in the blood, and deposits into the skin and mucous membranes, causing the yellow color we call jaundice.
So why does it matter? And if that's expected, how do we know when to panic? What is the difference between physiological and pathological jaundice?
It is entirely about the timeline. That is your ultimate clinical clue. Physiological jaundice happens after 24 hours of life, usually around day 2 or 3. This is the normal transition we just talked about. The liver is just catching up.
And pathological?
Pathological jaundice happens within the first 24 hours of life. If a baby is yellow on day 1, that is a massive red flag. It means something is actively destroying the red blood cells at a catastrophic rate.
And that something is usually a blood incompatibility, right? ABO incompatibility or RH incompatibility.
Right. And we must understand why we care so much. If it's just a yellow skin color, who cares, right?
But it's not just the skin. You mentioned that unconjugated bilirubin is fat-soluble.
That is the crucial detail. Because it is fat-soluble, it can cross the blood-brain barrier. If the levels get too high, that yellow pigment literally stains the basal ganglia in the brain.
Oh my God.
It causes a condition called kernicterus. This is not a slight developmental delay. This is permanent brain damage, irreversible hearing loss, and severe cerebral palsy.
It's a never event, right?
Yes, it is considered a never event in modern nursing. No baby should ever get kernicterus under our watch.
So what are the early and late concerning signs we assess for?
Early on, it's expected to see mild yellowing starting at the head and moving down the body, cephalocaudal progression. But if you see jaundice within the first 24 hours, that's your early concerning sign.
And the late signs?
The late terrifying signs that kernicterus is setting in are neurological. Severe lethargy, a loss of the Moro reflex, a bulging fontanelle, and a very specific high-pitched, shrill neurological cry.
So if you hear that cry...
Irreversible damage is likely already occurring.
Okay, let's talk about the causes of pathological jaundice. The incompatibilities. I know RH incompatibility is heavily tested.
Yes. For RH incompatibility to be a risk, you must have a very specific combination. Mom must be R negative, and baby must be R positive.
Because the negative mom's immune system sees the positive antigen on the baby's blood as a foreign invader, like a virus, and builds antibodies against it.
Exactly. But here is the trick. An Rh negative mom usually doesn't have those antibodies naturally.
Right.
She has to be exposed to Rh positive blood first, usually during the delivery of her first Rh positive baby, or during miscarriage or amniocentesis. That exposure teaches her immune system to make IgG antibodies.
So the first pregnancy is usually fine.
Yes. It's the second Rh positive pregnancy where her pre-made IgG antibodies cross the placenta and attack the fetus's blood.
Which is why we give the mom Rh immunoglobulin, or RhoGAM. We give it at 28 weeks of pregnancy, and again within 72 hours postpartum if the baby is confirmed Rh positive. It basically hides the baby's positive cells from the mom's immune system so she never makes those attacking antibodies.
Perfect. Now, I want to ask you a question that often trips up students. If a mom has blood type O, she naturally has anti-A and anti-B antibodies floating around in her blood from exposure to food and bacteria throughout her life.
Right.
Does that mean ABO incompatibility can happen on her very first pregnancy, unlike Rh?
That's a brilliant distinction, yes, because the type O mom already has those naturally occurring antibodies, and they are IgG-type antibodies, which are small enough to cross the placenta. They can cross over and attack a type A or type B baby during the very first pregnancy.
Exactly right. ABO incompatibility can absolutely cause severe pathological jaundice on baby number 1.
Okay, another classic exam trap. The Coombs test. The doctor orders a direct Coombs and an indirect Coombs. Which one goes to which patient?
This catches everyone. Think of it this way. The indirect Coombs tests the mom's theorem. It's looking indirectly for free-floating antibodies in her bloodstream that could attack a baby.
And the direct?
The direct Coombs tests the baby's cord blood directly. It is looking to see if maternal antibodies are already directly attached to the baby's red blood cells, actively destroying them. Direct is for baby, indirect is for mom.
So, priority nursing actions. If we have a high bilirubin level, our priority is phototherapy, putting them under the blue lights. How does light fix a blood problem?
It's an amazing process called photosommerization. The specific wavelength of the blue light hits the fat-soluble unconjugated bilirubin in the skin and alters its shape.
It changes it.
Yes, it turns it into a water-soluble molecule called lumirubin. Because it's now water-soluble, the liver doesn't have to conjugate it. The baby can just excrete it directly into their urine and stool.
Which means our nursing care under the lights is critical. We undress the baby down to a diaper only to maximize scare exposure. And we absolutely must protect their eyes with a specific opaque mask, or the light will damage their retinas.
And no lotions. Do not apply any ointments or lotions to the skin. The lights can literally cause thermal burns if the skin is coated in oil.
And the most important part, we feed them.
Yes. You cannot just leave them under the lights like a tanning bed. The light makes the bilirubin water-soluble, but the baby still has to pee and poop it out.
Right.
If they're dehydrated, the bilirubin just sits in the intestines, gets reabsorbed, and the levels stay high. Early frequent feedings are your best weapon against jaundice.
So memory anchors. Pathological is a problem right away. Physiological is punctual, arrives on normal time. If I only remember 5 things. Number 1, jaundice in the first 24 hours is an immediate reportable priority. Number 2, RH incompatibility requires a negative mom and positive baby.
Number 3, bilirubin is excreted in stool and urine, so feed the baby frequently. Number 4, protect the eyes and skin during phototherapy. No lotions.
And number 5, kernicterus is a never event. Watch for the high-pitched cry and lethargy.
Exactly. You protect the brain by clearing the bilirubin.
So we've looked at what's going on inside the blood. Let's shift our focus to the outside of the body. Next up, we are examining the highest yield structural anomalies you will see on exams and in the delivery room.
When we talk about structural anomalies, we were talking about failures of embryological development.
Right.
The organs didn't form or migrate correctly in the first trimester. These are highly visual, highly stressful situations that require absolute precision in your nursing care.
Let's focus on 4 major defects that show up constantly for the high-yield core. First, spina bifida, specifically myelomeningocele. This is a neural tube defect where the spine doesn't close, leaving a sac containing spinal fluid, meninges, and actual spinal cord nerves exposed on the baby's back. Why does this matter so much right at birth?
The clinical implication here is huge. Because the spinal cord is exposed, there's a massive immediate risk for central nervous system infection meningitis and permanent paralysis depending on where the lesion is located.
So what is our priority nursing action?
Positioning and protection. You must keep the baby prone, flat on their stomach or side lying.
Okay, here's a trap. If a test asks you about positioning a spina bifida baby and offers supine to let them sleep safely, recognize it as a lethal trap.
Yes. Laying them on their back will crush the dural sac, rupture it, and leak cerebrospinal fluid. Never supine.
And for protection?
You immediately cover the exposed defect with a sterile dressing moistened with warm, sterile saline. Do not use a dry dressing because it will stick to the nerves and tear them when removed.
That makes sense.
And you apply a flat barrier drape, basically a piece of sterile plastic, just below the defect. Why? To prevent stool and urine from the diaper area from traveling up the back and contaminating the spinal cord.
Okay, let's look at the abdominal wall defects. This is a classic visual trap on exams. Omphalocyl versus gastrocesis. Both involve intestines outside the baby's body. How do we tell them apart?
Let's start with gastroschisis. This is when the intestines protrude through a defect in the abdominal wall, usually just to the right of the umbilicus. The key diagnostic feature, there is NO-sac.
So the bowels are just completely exposed to the air.
Yes. And because they have been exposed directly to acidic amniotic fluid for months in utero, the bowel loops look highly inflamed, thickened, and angry red.
Now contrast that with omphalocyl. This is when the abdominal organs protrude centrally, right through the umbilical cord insertion, but they are enclosed in a neat, protective, translucent sac.
Correct.
I always remember it with the letters. Gastroschisis starts with G. Think G for gut spilling out, no sac. Omphalocyl starts with O. Think, oh, it's sealed in an O-shaped sac.
That's a perfect memory anchor.
Mm-hmm.
Now, clinically, both of these share the same concerning risks. Massive evaporative fluid loss, profound hypothermia because the organs are exposed to room air, and infection.
So what do we do in the delivery room before surgery?
You immediately place the newborn's lower half into a sterile, clear bowel bag, often called a silo bag, pulling it up to the axilla, the armpits.
Like a sleeping bag.
Exactly. It creates a greenhouse effect. It traps the moisture and the heat, and you must constantly monitor for vascular compromise. If that exposed bowel turns dusky, gray, or dark purple, it means blood flow is cut off and the tissue is dying. That is a surgical emergency.
Okay, the 4th structural anomaly is internal, but just as terrifying. Esophageal atresia, EA, and tracheoesophageal fistula, TEF.
Right. This is an embryological failure of the foregut to separate properly into the trachea for air and the esophagus for food.
Okay.
In the most common type, the upper esophagus ends in a blind pouch, like a dead-end road. and the lower stomach connects abnormally, directly to the trachea via a fistula.
Imagine you're in the nursery, you're a new nurse, and you're feeding a baby their first bottle. Suddenly, they start coughing violently, choking, and turning completely blue around the mouth.
Perfect.
You stop, you try to pass an orogastric, an OG tube, down their throat to clear the stomach, but the tube just stops. It hits a wall and coils back up in the mouth.
That is your massive alarm bell for ETEF. You literally cannot get to the stomach. Every drop of saliva or milk that baby swallows hits that blind pouch and immediately spills over into the lungs, causing aspiration and cyanosis.
So our priority is airway protection.
Absolutely. You make the baby strictly NPO. Yeah. You elevate the head of the bed to a Fowler's position.
Why elevate?
Because you have that fistula connecting the stomach to the trachea. You want gravity to keep the stomach acid down so it doesn't reflux up into the lungs. And finally, you place a specific tube, a Reblogal tube, into that blind upper pouch and put it on continuous low suction to suck up their saliva before they can drown in it.
Okay, so our top 5 things to remember here. Number 1, spina bifida priority is prone positioning, sterile moist dressing. Number 2, gastrocesis priority is a sterile bowel bag to prevent cold stress.
Number 3, ETEF presents with excessive drooling, cyanosis, and choking during feeds.
Number 4, pre-op EAT must be NPO with suction.
And number 5, always cover exposed defects to prevent infection and evaporative heat loss. Recognizing the structural failure immediately is what saves the infant's life while they await the surgical team.
Transitioning from protecting exposed organs from a harsh external environment, we bring ourselves to our next high-yield topic. What happens when the newborn's environment inside the womb was toxic or infectious? Let's talk about exposures, withdrawal, and sepsis.
This is a complex area because it requires you to manage not just the baby's pathophysiology, but often very complex psychosocial dynamic with the family.
For sure. Let's start with neonatal abstinence syndrome, or NAS, also known as NOWS, neonatal opioid withdrawal syndrome.
This is when a baby is born physically dependent on a substance the mother used during pregnancy, most commonly opioids like heroin, methadone, or prescription painkillers.
Right. And when the cord is cut, that supply abruptly stops. The newborn goes into severe withdrawal. The clinical picture of NAS is essentially a central nervous system and gastrointestinal system in absolute overdrive, hyperirritability.
Why it matters is that NAS can lead to fatal withdrawal seizures if mismanaged.
So what are we seeing on our assessment? What are the concerning findings?
Everything is hyper. They have a very distinct, excessive, high-pitched, shrill cry, severe tremors, hyperactive reflexes. They sneeze excessively, they yawn, they have watery diarrhea, and they are completely frantic but uncoordinated when trying to feed.
They want to suck, but they can't coordinate it, so they lose weight rapidly.
Exactly.
How do we treat it? I assume there's a protocol.
We assess their severity using a standardized tool, typically the Finnegan scoring system, or more recently the Eat, Sleep, and Console, the ESC model.
Okay.
The priority action is environmental. Before we reach for heavy medications like oral morphine or methadone, we provide low stimulation.
Dim the lights, keep the room quiet.
Exactly. You swaddle them tightly with their hands near their mouth to contain the tremors and promote self-soothing. You offer small, frequent, high-calorie feeds. You rock them gently. You are trying to manually calm a nervous system that is misfiring.
And this brings us to one of the biggest exam traps in all of nursing.
Oh, the naloxone trap.
Yes. The question will set up a scenario. A baby is born limp with severe respiratory depression. The maternal history notes chronic heroin abuse. Option A on the test will boldly say, administer naloxone, Narcan immediately.
And you must never choose that option. It is a lethal track.
Because it's an opioid, people think Narcan.
Right. In an adult overdose, Narcan is the savior. It knocks the opioid off the receptors and restores breathing. But in a neonate with chronic in utero exposure, their entire neurological baseline is dependent on that opioid. If you give Narcan, you instantly strip every receptor. It triggers an acute, massive, and potentially fatal withdrawal crisis. They will go into intractable seizures.
So what do you do for the respiratory depression then?
You treat the symptom mechanically. You ventilate the baby with a bag valve mask. You provide positive pressure ventilation until they breathe on their own. You do not induce the chemical shock of immediate withdrawal.
That is a pure safety priority right there. Okay, let's look at the other side of the exposure coin. Neonatal sepsis.
Newborn immune systems are incredibly weak. They do not have their own mature immunoglobulins, only what mom gave them. Sepsis can be early onset, meaning they caught it during delivery. Think group B strep, GBS, or E. coli from the birth canal. or late onset, meaning they caught it from the NICU environment, like from staff hands or IV lines.
We also hear a lot about torch infections.
Yes, TORCH is an acronym for specific congenital infections that cross the placenta and cause severe anomalies. Toxoplasmosis, other like syphilis rubella, cytomegalovirus, and herpes simplex.
And they have unique signs, right?
They often present uniquely with things like a blueberry muffin rash, which is actually dermal erythropoiesis, where the skin tries to make red blood cells because the bone marrow is suppressed, and hepatosplenomegaly, an enlarged liver and spleen.
But regardless of the bug, why is sepsis so terrifying in a neonate?
Because sepsis in a newborn does not look like sepsis in an adult. An adult gets a raging high fever, they get flushed, their white blood cell count spikes. A newborn doesn't have the immune capacity to mount a massive fever response.
They crash fast and they crash silently.
Yes.
So what is the concerning finding? What is the subtle sign we need to catch?
The absolute hallmark is temperature instability, which most often presents as hypothermia, not hyperthermia.
We get cold.
The baby gets cold. Why? Because infection increases metabolic demand, they burn through all their brown fat trying to fight it, and then they lose the ability to keep warm. They become profoundly lethargic, they have apneic spells, and they exhibit feeding intolerance. They might just spit up everything or refuse to latch.
My memory anchor for this, sepsis equals subtle and shivering. They don't fight back with a fever, they just fade.
Exactly. So if you see a baby whose temp drops to 36.1 Celsius or 97 Fahrenheit, and they are a bit lethargic, you don't just put a hat on them, you suspect sepsis.
And what is the non-negotiable priority nursing action?
You must obtain blood cultures and perhaps a lumbar puncture for CSF before starting broad-spectrum IV antibiotics like ampicillin and gentamicin.
Culture first, then kill?
Exactly. If you push the antibiotics first, you sterilize the blood sample. The lab will never be able to grow the bacteria, and we will never know what specific bug we're actually fighting, which means we can't narrow down the antibiotic therapy safely.
Okay, let's hit our top 5 for exposures. Number 1, naloxone is contraindicated in maternal opioid dependence. Number 2, NASCARE prioritizes minimizing environmental stimulation.
Number 3, neonatal sepsis presents subtly. Temperature drops are a massive red flag.
Number 4, always get blood cultures before pushing antibiotics.
And number 5, torch infections often present with a blueberry muffin rash and hepatosplenomegaly.
Okay, to wrap up our clinical rounds today, let's review a couple of essential medications that are heavily tested and clinically vital, and finally, touch on the hardest part of the job, when things don't go as planned and we have to deal with grief.
Medications in neonates are high stakes. They are microdosed. A tiny math error, moving a decimal point one spot, is a lethal error. You must know exactly why you are hanging a drip.
Let's start with one of the most stressful drips, prostaglandin E1 or PGE1.
This is a medication used specifically for ductal-dependent congenital heart defects, like transposition of the great arteries or severe coarctation of the aorta.
It's deeply counterintuitive to me. Usually we want the fetal structures, like the ductus arteriosus, to close after birth.
Right. Normal physiology dictates that when the baby takes a breath and oxygen levels rise, the ductus arteriosus constricts and closes forever. But in complex heart defects, the normal postnatal circulation is broken.
Right.
The only way oxygenated blood can mix with unoxygenated blood and get to the baby's brain is if that fetal connection, the ductus, stays open.
I think of it like a highway detour. If the main concrete bridge, the heart, is structurally broken, you have to keep the dirt road detour open. Without the detour, traffic stops, blood flow stops.
That is the perfect analogy. PGE1 is a continuous IV drip that forces the ductus arteriosus to stay open. It is an absolute life-saving doom to surgery.
So what's the nursing priority?
If that IV infiltrates or the pump stops, the ductus will begin to close within minutes and the baby will code. You must run it on a dedicated continuous pump and you never flush the line aggressively.
What's the main side effect we watch for? Exam trap alert.
Apnea. PGE1 frequently causes the baby to stop breathing, so they must be on continuous respiratory monitoring, and you must be prepared to intubate if necessary.
Next med. Caffeine citrate. Yes, literally caffeine.
We use it to treat apnea of prematurity. It stimulates the respiratory center in the medulla. It literally gives the premature brain a cup of coffee to remind it to breathe.
That's amazing.
It's highly effective and much safer than older drugs like theophylline.
And the universal med, erythromycin ophthalmic ointment.
This is prophylactic. It is a ribbon of antibiotic ointment placed in every newborn's eyes within an hour or two of birth.
To prevent what?
Its specific purpose is to prevent ophthalmia neonatorum, blindness caused by maternal transmission of gonorrhea or chlamydia during a vaginal delivery. Even for C-sections, it's standard of care.
Which brings us to our final and perhaps most important focus, the human side, grief care. Because despite the ventilators, the PGE-1 drips, and the surgical teams, sometimes we lose.
It is the hardest part of obstetrics and neonatology, because the expectation in this field is always joy. When loss happens, a stillbirth, a lethal anomaly, an NICU death, the grief is catastrophic. And as a nurse, you are the one standing in the room.
How do we communicate? Because the instinct is to say, I'm so sorry, they are in a better place, or you can always try again.
And those are the worst things you can say. They invalidate the current loss. We use evidence-based communication frameworks, like the nurse mnemonic for bereavement.
Never seen mnemonic, break it down.
N is, name the emotion. It sounds like you are feeling incredibly overwhelmed. U is, understand. I can't imagine how hard this is for you. R is respect. I'm so impressed by how fiercely you loved your baby. S is support. I'm going to be right here with you. And E is explore. Tell me what you are thinking about right now.
Our priority action is to not shy away from the room. We don't avoid the parents because we feel awkward.
Presence is your greatest intervention. You ask what they need. You offer to take photographs, arrange a baptism if they desire, take handprints, or simply wrap the baby warmly so they can hold them as long as they want. You treat the baby with profound dignity.
And what about the nurse's grief?
This is clinically vital. Without processing these events, nurses suffer from secondary traumatic stress, or STS, and compassion fatigue.
You just burn out.
You become emotionally and spiritually exhausted. You detach from the clinical picture, and patient safety suffers. Self-care and formal peer debriefing are clinical requirements, not luxuries. You cannot pour from an empty cup.
Top 5 for this final section. Number 1, PGE-1 is life-saving for severe congenital heart defects by keeping the duct open. Number 2, caffeine treats apnea of prematurity.
Number 3, eye prophylaxis prevents maternal transmitted blindness.
Number 4, the NRSE mnemonic is your tool for therapeutic communication.
And number 5, self-care and peer debriefing are clinical requirements, not luxuries, for OB and NICU nurses.
Wow. Okay, we have covered an immense amount of ground today. I want to congratulate you, the listener, on absorbing a massive amount of high-yield OB and newborn nursing material. We've gone from the mechanics of surfactant and the vaginal squeeze through the metabolic crashes of insulin and cold stress.
We've navigated the yellow flags of bilirubin and kernicterus, visualized the terrifying structural defects, managed severe withdrawals without Narcan, and covered life-saving drips.
Reiterate to yourself that mastering this specific foundational material will heavily impact your clinical judgment. It changes how you look at a baby in a warmer.
It's not just about passing an exam. It's about seeing the subtle shivering of sepsis before the baby crashes, or knowing exactly why you are checking that jittery baby's sugar instead of just swaddling them.
When you step onto the floor for your next clinical rotation, visualize these scenarios. Look closely at the baby. Trust your gut when a baby's temperature drops or their respiratory rate climbs over 80. You know the pathophysiology now. You know the why.
And remember that true clinical intuition isn't magic. It is built entirely on a foundation of solid, unshakable knowledge. You have that foundation now.
I want to leave you with a final reflection to mull over as you study or drive to your next shift. The ultimate paradox of being an elite NICU or OB nurse is that you must master the most intense, high-stakes medical technology, the ventilators, the microdose drips, the complex surgeries.
You have to be a scientist?
Yes, but simultaneously, you have to understand that sometimes the most powerful, life-saving intervention you can provide is the simple, low-tech magic of a tight swaddle, a dark room, or just holding the hand of a grieving parent.
Medicine and technology keep the baby alive, but nursing protects their humanity.
It all comes back to that broken X-ray machine we talked about at the beginning. You can't always see the trauma. You can't always measure the withdrawal or the grief on a scan. You have to be the one to look closely at the murky waters, interpret the subtle signs, and advocate fiercely for the tiny patient who has no voice. You are their monitor. You are their safety net. Stay sharp, trust your training, and we'll see you on the floor.